So we're continuing to talk about local anesthetic techniques. We already talked about the infiltration, line blocks and pain busters, the patches and the EMLA cream. So we're going to start today by talking about blocks of the head. And so we're going to start first with infraorbital nerve blocks. So infraorbital nerve blocks the infraorbital nerve, which is a continuation of the maxillary nerve. And it provides anesthesia for the upper lip and nose, the roof of the nasal cavity, and the skin that's ventral to the infraorbital foramen. On this particular diagram, it's actually located right here at the letter A and coming in from the front. So there are two different options for approaches for the infraorbital nerve block. You can do the intraoral or extraoral approach. The basic difference is that in both situations, you're going to go into the infraorbital foramen with your needle, but you're either going to go through the skin or you're going to go through the mouth. And so what you need to do is you need to locate the infraorbital foramen and then feed your needle into the foramen itself. So to do this can be a little bit challenging. In most situations, it's finding the infraorbital foramen that's the hard part. You need to use a small enough gauge needle that you can feed it into the infraorbital foramen. Typically, this is used for things like rhinoscopy. So this will help for the normal rhinoscopy where they're actually looking at the nose itself. It will not help for the retroflex part where they're going through the mouth and looking behind the nose through the pharynx. The typical complications from this are going to be bleeding and incomplete blockade. So we have an example for you of performing an infraorbital nerve block in a dog. And this is actually a pretty good dog to do this in. It's got kind of a long nose. And so they keep palpating for that infraorbital foramen. And they're utilizing a spinal needle in order to do this because we want to know where the bevel is facing. And so they've actually fed the needle into the foramen. You kind of saw that pop as it slid in. And they're going to take the stylet out and they're going to rotate it so that the bevel of the needle is facing in towards the nose. And if you do this right, when you put your needle in, you won't be able to move the tip of the needle at all because it's going to be seated in bone. So the important things after you get your needle where you think you want it is that you're going to attach your syringe, and you always want to make sure that you aspirate back to make sure you're not in a vessel before you inject. And usually injecting under pressure will force the local anesthetic to go farther back. And then pull the whole needle out. So pretty simple to do, easy, not a lot of complications. Unfortunately, in this particular case, we saw something that I had never seen before, and that's what we got after. So that's an unusual complication right there. The dog did fine, but it was not something that we expected to happen. Usually, if you're going to get bleeding, it's going to be bleeding through where you put your needle, not out of the nose. In cats, you can also do an infraorbital nerve block, but they don't actually have a true infraorbital foramen. They just have this big, They just have this big hole that's basically at the bottom part of their zygomatic. Feeding a needle in through that is a pretty easy thing to do, and again, you can use an extraoral or an intraoral approach. Using a 25 gauge needle is probably your best choice. Some of the adverse effects in this, addition to the bleeding and the possibility of an incomplete blockade, is given the location of this foramen, is that you could accidentally puncture the orbit of the eye or the globe itself. You could also lacerate any vein or artery that's traveling along with the infraorbital nerve. So the key to doing that is just make sure you're not using a really long needle, and if the eye starts bulging out, stop what you're doing. You can do an infraorbital nerve block in almost any patient that you want. And this is a skull from a llama, and llamas have an infraorbital foramen too. Are there any questions about infraorbital nerves? Probably the most common use for infraorbital nerve blocks is going to be for dentals. Mandibular nerve blocks are also pretty easy to do. The mandibular nerve is a branch of the trigeminal. And so you're going to block the whole bottom of the jaw when you do a mandibular nerve block. So you get desensitization of the mandibular teeth, the canines, the incisors, the skin and mucosa on the chin and lip on that side only. And so if you want to block both sides, you'll have to do bilateral. To palpate for the mandibular foramen, it's actually going to be located right where the tip of this needle is. In most animals, you can palpate it on the inside of the jaw. In really large animals, or if you say you have an English bulldog where they have a lot of tissue, that can be a little bit challenging. But you need to advance your needle up the ramus of the mandible in order to block the nerve. And again, you're going to want to make sure that you aspirate back to make sure you're not in a vessel before you inject. Typical uses for this block are for dental extractions, and if they're going to do a mandibulectomy, this would be a good option. And again, the complications include bleeding and incomplete blockade. And again, you can do it in almost any species, like alpacas. In horses, you can block the mandibular alveolar nerve, but you have to do it at the mental foramen. So it's really challenging to try to do one at the mandibular foramen. And so you'd have to go through right here at the point of the mental foramen in order to block the mandibular nerve. And that means you're going to need to use a really, really long needle. And so you can sort of tell from these pictures, especially the one that's coming up next, that they were a little bit older. These are probably taken in the 80s. But that needle is actually a spinal needle, and I think it's 5 inches long. And they actually did that block in order to repair a mandibular fracture in a horse. So if you have a really good block, you can do these in awake patients, and you can do the fracture repair in a horse when it's still standing. Mental nerve blocks are a little bit more challenging because palpating the mental foramen can be a little bit challenging. In small patients, it's actually you're not going to be able to feed your needle into the foramen itself. So for dogs, you can put your needle right in here at where the letter D is and block the mental nerve. In cats, you won't be able to feed your needle in through that foramen, and so you'll have to block over it. The point of doing a mental nerve block is that you'll get anesthesia of the lower lip and the rostral portion of the mandible only, so the rest of the jaw is still going to have sensation. Typical uses are going to be for like bilateral blocks for a mandibular symphyseal fracture, really common to do in cats as well as dogs, especially Yorkies. And complications again include bleeding and incomplete blockade. For you large animal people out there, local anesthesia for dehorning is going to be slightly different in goats and in cattle. The nerves that you're going to block are going to be a little bit different. In goats, you need to block 2 different nerves, the corneal branch of the zygomaticotemporal, as well as the corneal branch of the infratrochlear. And so this diagram shows you where you need to do your blocks at, and normally what people do is they kind of draw a line from the lateral and the medial canthus of the eyes, and it goes up to where the horn base is. And so this is our patient. Pretty cute. I think he was sort of the opinion that if he couldn't see you, you couldn't see him. He refused to look directly at us. We ended up sedating him, so now he looks a little bit drunk. And then we blocked for dehorning. And so what we would do is we would draw a line from the lateral canthus of the eye up to where the base of the horn would be, and you're going to block all along that line. Some people will do a line block there. Some people might just do a bleb and allow for infiltration. You can use 22 gauge or 25 gauge needles. Either would be appropriate. For dehorning in a cow, it's a little bit more involved. They tend to have a lot more tissue. It's one of the reasons you should do these when they're very young. And you would need to block just the zygomaticotemporal nerve. It'll block the horn and the base of the horn. If in larger cattle though, it's probably not going to be sufficient. So most people would also do a ring block around the horn itself. Limb blocks are going to be the most common thing that you're going to do in private practice, especially 3-point blocks or ring blocks in cats. You can do brachial plexus blocks and do them well in regular practice. There is a technique for performing what's called a RUM block, which stands for radial, ulnar, median, and musculocutaneous. And then we're going to talk about intravenous regional anesthesia, which is kind of my favorite. I think it's a little bit challenging, but it's pretty fun. So for 3-point blocks in cats, we usually use ropivacaine because it has a longer duration of action than lidocaine, but a short onset like lidocaine. And when you do this block, you're going to block 3 different nerves. You're going to do the radial nerve, the median nerve, and then 2 different branches of the ulnar nerve. Typically either 22 or 25 gauge needles are used, and I would prefer the 25. And when you do this, you're going to place your needle in 3 different areas. So on the dorsal surface, you kind of place it right in the middle of the limb. And when you do this block, you're going to have to go very deep. You're going to feel kind of like you're scraping the bone with the tip of your needle. And you're going to basically infiltrate all over this area on the dorsal surface. So the way to do that is to palpate for the bones of the carpus, go more proximal and right in the center of the limb itself. You want to insert your needle, and then you always want to aspirate back, make sure you're not in a vessel. Usually we would get this spread by fanning the needle from side to side. Never in and out, always side to side. For the palmar surface, you're going to do 2 different blocks, and again you palpate for the carpus. And go for it. There's 2 notches right here on the palmar surface where you're going to block right there. And so for a normal sized cat, we're going to use about 1 ml of a 0.2% solution and 0.4 mils for the dorsal surface, and then 0.3 and 0.3 for the palmar surfaces. 3-point blocks I think can be helpful. There are some studies that show that they're not very effective for patients when they're having a declaw. I think there isn't a lot of downside to doing it, and if it's helpful in any patient, I think I'd probably give it a try. Brachial plexus blocks in dogs can be used for procedures, anything from the elbow down. So there are about 11 different nerves that comprise the brachial plexus in a dog, but the ones that we really worry about are going to be the radial, the median, the ulnar, musculocutaneous, and the axillary nerves. And like I said, this will block from the elbow down. So even though when you do a brachial plexus block in a dog, you're going to put your needle in at the point of the shoulder, it's really only going to be effective for any fracture, for example, at the point of the elbow. Radius and ulna, anything at the carpus would also be blocked. There are 3 different basic techniques for doing this. One is what's called the blind technique. One uses ultrasound guidance, and the other uses a peripheral nerve stimulator. So it's really easy for me to say that performing a brachial plexus is simple. And when you look at a diagram like this, it looks pretty simple. But when you look at this picture, you see that the brachial plexus is a lot more complex. So to do the blind technique, you need to have a patient that's either sedated or anesthetized. You can do this in an awake patient, but it's easier if they're under anesthesia. You need to insert your needle that's medial to the shoulder joint and direct the needle parallel to the vertebral column. The biggest thing that you want to do is you want to lift up on the limb to separate it from the thorax and insert your needle at the point of the shoulder, and just make sure you don't enter into the thorax. Which is a known complication of doing this procedure. With your non-dominant hand, you're going to palpate for the axillary artery, which is traveling alongside the nerves of the brachial plexus. And so with this left hand, this is one of our techs, and she's pulling up on the limb, and she's also palpating for that axillary artery. And so that's going to give her an idea of how far she needs to go in with the needle, and she's going to insert her needle right there. To use a nerve stimulator, everything is basically going to be the same, but you need to have a patient that's anesthetized. Nerve stimulation can be somewhat painful, and I made a mistake one day of putting a nerve stimulator on myself, and it was not pleasant. So you definitely don't want to do this in an awake patient. Your insertion of the needle is going to be at the same point, but to do this, we use what's called Teflon sheathed needles. And so the needles, the only part of the needle that will stimulate the brachial plexus nerves is going to be the very cut tip of the bevel. And use of a nerve stimulator gives you a twitch like that at your carpus. And that's how you know where you're at and where the brachial plexus nerves are. And redirecting your needle so that you get the best stimulation, so that you get that flex, the extension at the carpus. But you also want to turn down the stimulation with your nerve stimulator. So the best reaction, the best block that you're going to get is when you get that twitch at the lowest possible stimulation. It means that your needle is closest to the nerve. Make sense? So one of the things that you can't see on here, so there's a port, actually you can see it. So this needle has the stimulator attached here, and then it has the syringe that's attached to a port, and it goes in through the needle, and so it's stimulating the cut tip of the needle is stimulating the nerve, and then as you inject that fluid, your local anesthetic, it pushes the nerve away from you. And so you're going to have to continuously find the nerves of the brachial plexus. So you inject a little bit of local anesthetic, and then you turn your stimulator up, and you find more nerves, and you get that twitch, and you turn your stimulator down, and you inject more local anesthetic. To do this could take you a good 45 minutes to get a good block. We probably don't take a good 45 minutes because most of these patients are going to stay anesthetized. If you were a person having surgery on your limb, they could do this with you and you would be awake and they would never anesthetize you and they could do the surgery with you awake and you'd never feel a thing. So the alternative is to do ultrasound guided, and a lot of times they'll do ultrasound guidance along with a nerve stimulator. And so they have all these very challenging diagrams to kind of tell you where all the muscles and everything you need to know are. And then you're going to get an image that looks like that. I am not an ultrasonographer. If somebody were to point that out and tell me, yep, that thing right there, that's a nerve, I would believe them. But I'm not sure that I would pick that up on my own. And so people who do this a lot are going to be people that this is like a huge part of their research. Some ultrasonographers will do this, but this is not something that I would do in a patient that's under anesthesia because I'm not good at ultrasound. There are some reports though that you get a better block if you use ultrasound in addition to the brachial or the nerve stimulator. An easier block in some respects to do would be to do what's called a rum block. And again, it will block everything from the elbow down. So also still good for like a condylar fracture, good for a radius fracture or an ulnar fracture. You don't have to have fancy equipment to do this, but you do need to know your anatomy. And this is kind of the description. So I'm not going to read this to you, and you do not need to know how to do this for the exam. I'm not going to say, like, at what point do you need to divide your, I don't know, what does it say? Radial nerves located at the junction of the middle and the distal thirds of the length of the humerus. So I'm not going to ask you anything like that. The thing about rum blocks is that you definitely need to know your anatomy, and you need to be able to move muscle bellies out of the way, which I find a little bit challenging. And in this picture, you can see somebody attempting to do a rum block and not doing a very good job of it. And the reason that you know that is that they're way too far distal. They should be probably more like up here. The other thing about doing a rum block is that you have to reposition your patient. So this is on the lateral aspect of the limb, but then you have to turn them over in order to get the medial aspect of the limb to block the ulnar, the musculocutaneous, and the median nerves. And again, you have to move muscle out of the way, and you have to divide the length of the median, the humerus, into different parts. And this person did a much better job at the medial aspect. And you can see right there, they're pretty much where they want to be. So one of the things that I don't like about rum blocks is that you're probably going to get really good at them if you do them a lot. But even if you're really good at them and you do them for a paper, you only block the ulnar nerve about 19% of the time. So it'd be really hard to do a block like this on a patient and then be able to do this procedure when they're awake. You'll block the radial nerve 94% of the time, so you got a better shot at that. But the others, you know, it kind of ranges from 19 to about 69%. So rum blocks can be a good option in some patients, but probably not great for all patients. Intravenous regional anesthesia is something also known as a beer block, and that's B-I-E-R, not B-E-E-R. And usually it's used for anesthesia of an extremity that's distal to a tourniquet. So in order to do this, you are going to have to place a tourniquet. It's nice to have a blood-free surgery site for the surgeons. And so typically we would do this if they were taking a foreign body off from a paw, if they're doing biopsies, or for a digit amputation. I had a really great video, I thought, and then I saw that the tourniquet fell off about 3 times, and you have to place an S-mark bandage, and it's kind of a pain, and the video didn't turn out as well, so unfortunately you can't see the tragedy that we had in attempting to do this block. But usually what you have to do is you have to place an S-mark bandage. So does everybody know what that is? No. All right, so for an S-mark bandage, what you have to do is go against everything everyone has ever taught you about placing vet wrap on a patient. Tighter than tighter than tight. And so basically you have to get it so tight that you're occluding all blood flow, and you start at the distal part of the limb and you wrap up. And so you're trying to push all of that blood up, and then you place your tourniquet, and then you take your S-mark bandage off. And so the fun part comes when you then have to try to inject into a vein. So you got all that blood out of there, how are you going to find the vein? Well, not all the blood's going to be out. And so what some people will do is they'll actually place an IV catheter first, and then they'll do their S-mark bandage and place their tourniquet, take their S-mark off, and then they already have a catheter placed into a vessel. So there's 2 alternatives for how to do that. You can only use lidocaine for this block. And so what happens is you inject into a vessel, and the lidocaine spreads out and out of the vessel itself. So when you inject it in, you think you're blowing the vessel, but you're not. Veins are really distensible. And so you inject this lidocaine into the vessel, and it's going to gradually leach out into the surrounding tissue. And then as soon as you take that tourniquet off when they're done with that procedure, any lidocaine that's in the vessel is then going to go systemic. And any lidocaine that's in the tissue is then going to be reabsorbed over about the next half an hour. So you need to make sure that you're staying, usually you want to stay about 2 milligrams per kilogram. And you could go up to 5, but I probably wouldn't unless I needed a huge volume. And so they're actually doing a beer block in this patient so that they can do biopsies of the paws, and they're injecting into a vessel. And they have a kind of a large volume for this small area, but what you would see if this was a video would be that the veins would be very distensible, and then it would slowly leach out of the veins into the tissue. Probably the most common use of IVRA is in cattle, and they do this for local anesthetic injections. They do it for antibiotics. They do it for a lot of different things. Contrast injections sometimes if they're trying to diagnose something. And so IVRA is more commonly used in large animal patients, but you can definitely do it in small animal. Regional anesthesia usually occurs within 10 minutes and will stay there as long as the tourniquet is in place, and the tourniquet can only stay in place for a maximum of 2 hours. And so that's a maximum of 2 hours, so you got to do your block, prep your patient, have them get the surgery completely done in that amount of time. The only local anesthetic that should be used is lidocaine because you were injecting it IV. If you leave your tourniquet on for too long, you can get reversible shock if it's for 4 hours, but your patients can die if you leave it on for more than 8. And so there is a picture here. This cat actually had a tourniquet that was left on way too long and ended up having to have his paw amputated. So finally we get to epidurals and spinals. And you guys will all have the opportunity to do epidurals when you're in the clinic. Usually we do lumbosacral epidurals in small animal. And so this needle is actually placed at the lumbosacral junction in a dog. And what you'll notice is that the lumbosacral space is right here, but the cord is actually up here. So you shouldn't really get a spinal if you're placing your needle appropriately at the lumbosacral junction. So what's the difference between an epidural and a spinal? Well, kind of simple in some respects. If you're in the epidural space, you're doing an epidural. If you're in the spinal or subarachnoid space, you're doing a spinal. And so what you'll notice clinically is that if you're doing a spinal fluid will come out of your needle. One of the nice things about that is that you know exactly where you are. With an epidural, you place your needle, you get good landmarks, you get those nice pops that I'm going to show you here in a second, and everything about it is telling you that you're where you want to be, but sometimes you might not be. And so having a spinal can be a good thing because if you get spinal fluid back, you know it's going to be effective. The bad part about doing a spinal is that you could potentially increase intracranial pressure in some patients. It's not going to last as long as an epidural would. And if you get cranial spread, which you will with a spinal, you can have some detrimental effects, especially if you're using a local anesthetic. So the duration of action is different. Location tells you where you are. And so you should usually use different doses. So what we usually would do would be to drop enough drugs to do an epidural. And if you accidentally got spinal fluid coming out of your needle, then you decrease your dose by half. So there are some species differences when it comes to where the spinal cord ends. Dogs, it's usually L6, L7. Cats can be more variable, L7 to S3. So you're way more likely to get a spinal in a cat than in a dog. Horses, S2, and cows are at S1. So to do an epidural in a dog, your spinal needle with a stylet is placed at the lumbosacral space. And this is Sue. She's palpating for that space in this dog. When you place your needle, you'll get a distinct pop when the needle is advanced through the interarcuate ligament, which is also called the ligamentum flavum. But you're actually going to be going through 3 different sets of ligament. The first one is the dorsal spinous ligament. And a lot of times people go through that when they go through the skin and they don't really realize that it's happening. There's interspinous ligaments that you also go through, and most of the time it just feels like normal tissue. Sometimes in some animals that are older, it can feel, for lack of a better term, and I'm sorry if this is gross, but it feels a little crunchy. And it's probably because they're becoming somewhat calcified. And then you'll get that very distinctive pop when you go through the ligamentum flavum. You shouldn't get any blood or spinal fluid, and you don't need to aspirate back when you're doing a lumbosacral epidural. And you should feel minimal resistance to injection. And so Tim Voigt put this together to demonstrate what you need to look at and what you're going to do when you do an epidural in a dog. And so usually you place your middle finger and your thumb on the cranial parts of the wings of the ilium and your index finger in the space between L7 and S1. And your needle goes in and you're going to go through the skin, and that first pop that you're going to go through is that dorsal spinous ligament. And then all those are going to be interspinous ligaments. And that last dramatic pop is going to be through the ligamentum flavum. And then you'll get either negative pressure, so you can do a hanging drop technique like you would in a cow, or you can do a loss of resistance technique, which Dr. Lurch is going to show you in this video. Actually, come on. This is not fair. And for whatever reason, that is not working. Let's see. Sorry. Apparently, we are not going to have a video of Dr. Lurch today. So for epidural anesthesia, we typically do 1 mil per 5 kilograms of body weight, or 0.2 mils per kilogram total volume. We typically would use a combination of a local anesthetic and a preservative-free morphine. So we would do 0.1 milligrams per kilogram of morphine, or you can do a combination of those 2 drugs. If you use just lidocaine, your epidural will last for about an hour and a half. If you're going to do bupivacaine or ropivacaine, it could be 3 to 5 hours, sometimes even longer. If you're using epidural astromorph, it will be about 8 hours of analgesia, but not anesthesia. So some advantages of epidural anesthesia are that you get good muscle relaxation. You'll have post-operative analgesia, minimal effects on the body depending on the doses that you use, and they're typically low cost. Lidocaine is pretty cheap, spinal needles are pretty cheap, so really it's just your expertise. Epidurals will provide anesthesia anything caudal to the umbilicus, so the volume that we typically use should get you up to the level of T13. And so that would be a great thing for dogs having a cesarean section. Any surgery on the hind limbs, if you have a dog with pelvic fractures, or any kind of perineal surgery like an anal sacculectomy. So some complications of epidurals are that you could get inadequate anesthesia due to faulty technique. You weren't where you thought you were. The animal, if you're going to do this in an awake patient, they could be awake during surgery, so they could potentially still move, at least on their front end. Your surgery time will be a little bit limited if you're going to do this in an awake patient. You can get hypotension, respiratory depression, or apnea if you use a huge dose of local anesthetic, or if you get excessive blockade through like spinal, through doing a spinal. And if you do accidental administration into the subarachnoid space, in some patients, you could potentially increase intracranial pressure. So there are some absolute contraindications to doing epidurals. Hypovolemia and hypotension, if you're going to use a local anesthetic, would be an absolute contraindication. If local anesthetic administration into the epidural space is going to cause vasodilation, so you're going to make their hypovolemia and hypotension even worse. If you have a patient with a bleeding disorder, you don't want them bleeding anywhere around the cord, and so if you accidentally hit a venous sinus that exists in the epidural space, you can cause bleeding around the cord, and that's going to cause you some major problems later. And any kind of skin infection over where you're going to stick your needle. So you don't want to introduce infection around the cord either. Epidural opioids, it doesn't really matter what it is that you're injecting into the epidural space. The technique is going to be the same. Usually we want to use drugs that don't have preservatives because preservatives can affect the spinal cord. And so typically morphine is the one that's used because it's the least fat soluble, so it'll last the longest. In people, they'll often do combination epidurals. And so for pregnancy, for example, in labor, they'll do an epidural using fentanyl because it'll have an immediate onset. It's very fat soluble. And they'll also add morphine to it so that it'll have long-lasting analgesia. Some advantages of epidural opioids are that you get profound somatic and visceral pain relief. It can actually be really helpful. No motor blockade, so your patients will still be able to walk. You won't get sensory blockade, and so that's good in some patients, not good in others. You don't get depression of the sympathetic nervous system, and if you get any systemic side effects like sedation, you can reverse those with naloxone and still maintain your analgesia around the spinal cord. Epidurals in cats are a little bit different. They have different anatomy, so their dorsal spinous processes are shaped differently, and so that can be a little bit of an issue for when you're placing your needle. Their spinal cord ends a lot more caudally, or at least it's more variable than it is in a dog, so you're more likely to get a spinal rather than an epidural. Local anesthetics in cats tend to be a little bit more sensitive to the effects of local anesthetics, and so I wouldn't typically do an epidural using a local anesthetic in a cat, at least if I'm doing it in a lumbosacral position. And lumbosacral epidural, the dose is the same. So if you did, it would be the same as in a dog, 0.1 milligrams per kilogram if you're using Astromorph. And if you get a spinal, then you reduce your volume by half. So to do an epidural in a cat, you're going to palpate for the same landmarks, the dorsal spinous processes, and put your middle finger and your thumb on the cranial parts of the wings of the ilium, and then palpate for the space between L7 and S1. And because their anatomy is so different, a lot of times you're going to end up with your needle in a very perpendicular direction. So it's going to be sort of straight up, and that's pretty common in a cat. There's a technique for performing coccygeal epidurals in cats, and this would be the same technique that you would utilize in cattle or horses, where you're placing it at the last movable vertebrae is probably going to be the most common. In cats, you can do sacrococcygeal, or you can do coccygeal 1, coccygeal 2. And so to palpate for the coccygeal epidural space, you're going to palpate the space between the sacrum and coccygeal 1, or CO1 and CO2. And usually you can do that by pumping the tail like you would in a cow. You'd insert a 25 gauge needle right on midline. And in this situation, you would want to aspirate back because you want to make sure you're not in a vessel. The advantage of doing a coccygeal epidural is that you can use local anesthetic. You are nowhere near the spinal cord back here, which is great. And you're also not going to get cranial spread of local anesthetic, so the toxicity issues aren't going to be the same. It's been described for use in cats with urethral obstruction, and the authors postulate other possibilities like for dystocias or tail amputations and perineal procedures. Unfortunately, the group that actually did this technique first hasn't provided any studies on efficacy. So it could be helpful. It's probably not going to have a huge downside, The benefits are that you could use local anesthetic, and they report complications like bleeding and incomplete blockade, the same as if you were doing a lumbosacral epidural. They are working on the efficacy studies though, so it'll be interesting to see what they come out with. Epidurals in cows are very similar to cats in that you're going to go in the coccygeal area and you're going to palpate for the first movable coccygeal space by pumping the tail. You can do an epidural or you can place an epidural catheter, and we're going to talk about epidural catheters next. And you can do the same thing in horses. The complications are basically the same. In large animals, you worry a lot more about the use of local anesthetics, especially large doses, because if you push them far enough forward, you could make it so your patient drops to the floor. And if you have a 1,000-pound animal, that's going to be a little bit more disconcerting than if you have a 5-kilogram animal. So epidural catheters can be used for long-term pain management. These would be patients that would be staying in ICU, for example. We placed this epidural catheter in a dog that had osteosarcoma of a rib, and so it had a rib resection. To place an epidural catheter, typically still you're going to place it at the lumbosacral junction. And so you can see the catheter right here, and it's actually feeding into the epidural space. But because of the location of the surgery, we actually fed the tip of the catheter quite far. And so you can see it all the way up here. And finally, the tip of the catheter is sitting about right here at about T5 to T7, somewhere in there. And so this was for a rib resection. You wouldn't do that for a hind limb procedure for pelvic fractures, but it kind of shows you what you can do. It is useful for prolonged infusions or intermittent injections of either local anesthetics or opioids. Some of the issues that's associated with them is that you have to maintain them, and so that can be challenging in a patient that is moving around. Placement of them is not always the easiest thing. In some patients it's really easy, greyhounds for example, but in some patients it's not that easy. They are costly, so it will increase the cost for your client, but one of the benefits is that you get infiltration of these drugs and they're going to have an effect at the spinal cord, and typically you don't get the sedation that comes with injectable morphine or hydromorphone, for example. And you can only use these in hospitalized patients, so you can't send a patient home with an epidural catheter. One of the other things that's really nice about it is that if you do happen to have infection associated with the epidural catheters, they do tend to be self-limiting. So as soon as you remove the catheter, they tend to go away. So some complications of all of the local and regional anesthetic techniques are that you can get bleeding, you can get toxicity if you're using the wrong kind of local anesthetic in the wrong manner, for example, using bupivacaine IV, or if you're using large volumes. You can get incomplete blockade, so your block isn't going to work as well as you thought it would. And you can do accidental intravenous or intra-arterial injections, which could have some catastrophic effects on your patients. And the way to avoid that is always make sure you aspirate back before you inject. So we already talked about what the potential adverse effects of epidurals are and when you should avoid them. So I have some sample questions for you before you guys get ready for your exam. So regarding local anesthetics, is the following statement true or false? The ionized form of the drug is responsible for its activity. False? It's true? How many people say true? How many people say false? It's true, right? What's the maximum dose of lidocaine you should use during local tissue infiltration? What's that? 8? E. Okay, I was like, there's no 8 up there. Yeah, E, 10 milligrams per kilogram. Remember, goats tend to be the most sensitive to local anesthetics for infiltration, and their toxic dose, you need to stay below 10 milligrams per kilogram. So in every other patient, if you stay below 10 mg per kg, you'd be doing fine. Which 3 nerves do you block when you perform a 3-point block for a cat that's having a declaw? Which one? D? Yeah, it's D. You're going to block the median, the radial, and the ulnar nerve. 3-point block sort of tells you that it's 3, right? So that sort of counted out A, B, and C. And so do we have a humeral nerve? I don't know. It's been a long time since I took anatomy. You tell me. No? There's no humeral nerve? Well, there you go. So for the exam, I won't ask you for specifics on how to do a block. We already gave you some examples. You don't need to divide the humerus into thirds when you're doing a run block. I don't need to know that. Anatomy is fair game, but only in the detail that's in these slide notes. So I'm not going to go into a bunch of stuff that you guys learned in first year and when you had to memorize the dice book backwards and forwards. And there are going to be some general questions as well as some case-based questions. And it is all going to be multiple choice. Are there any questions about local anesthetic techniques or pharmacology? Yes?
Could you just explain how you do intravenous anesthesia when you're replacing like the bandage?
Okay, so when you do this, you're going to be doing it, usually it's going to be in a limb, the distal part of the limb. And so what you would do is the first thing, you could either place a catheter before you do anything else, or you can decide not to do that and just do an IV injection. And so once you've made that decision, you're going to place what's called an Eschmark bandage, which is that vet wrap that's tighter than tighter than tighter than anything ever. And you're going to force all the blood as you roll it up the limb. And then you place your tourniquet at that point. So it's keeping all the blood up. And then you take your Eschmark bandage off and you inject into a vein. So either into the catheter that you pre-placed or into the vein, any vein that you can find. So there'll still be some blood in there, so you'll know you're in a vessel. Veins are really distensible, so it's going to look like the vein is blowing, but it's actually not going to be. And then you can if you can keep aspirating blood back after every mil or so, then you'll know that you're still in the vein. And so it's good for as long as the tourniquet is in place. Yes? Well, that's why you can only keep it there for 2 hours. It is kind of a long time, yeah. And so that's why when we do this, it's usually for something simple like a toe amputation or a mass removal. I wouldn't recommend doing this for, like, say, a radius ulnar fracture. This would not be my pick. Does anything in this building ever take 2 hours? Especially not a fracture. We're pretty fast, but sometimes we're not that fast. Are there any other questions about local anesthetic techniques? So somebody asked me if I could place the PowerPoint slides on Carmen. So I did that for this lecture and for the one previous.